Okay, thank you for coming. This is the session on innovating for development. We have three terrific speakers here today who have inside views into the promise and pitfalls of trying to use advanced technology in appropriate ways to improve the health, wealth, and well-being of people in low-income regions. The speakers will be coming at this topic from three different perspectives: from a philanthropist who is a leader at the largest nonprofit donor working in this areas, and a technologist and an inventor who actually oversees a large team of engineers and scientists producing new products like this, and a journalist who covers these sorts of projects in Kenya. Each of the speakers is going to give a 15 to 20-minute talk. Please hold your questions to the end, and we'll have a discussion among the panel with questions from the audience then. Our first speaker was born, raised, and trained as a physician in South Africa before attending Oxford University as a Rhodes Scholar and then earning a PhD in mathematics at the University of Chicago. Trevor Mandela is now the president of the Global Health Division at the Bill and Melinda Gates Foundation, where he leads many projects to develop high-impact interventions against the leading causes of death and disability in developing countries, including HIV, tuberculosis, malaria, pneumonia, diarrheal diseases, and neglected tropical diseases. Please welcome Dr. Trevor Mandela.
Thanks, Wade. So, advancing it. Okay, thank you. I've just gotten back from a trip through Africa, meeting some of our folks in the field and governments in Ethiopia and South Africa. And this convinces me more than ever that there is an amazing narrative to be told around the application of science and technology to advancing development in sub-Saharan Africa, South Asia. And it really is a partnership with the audience over here that I think is going to do this effectively. So myself, my group at the foundation are absolutely at your disposal in terms of providing you with any substrate that you might need to tell what I think is a wonderful story that hasn't quite been heard yet. So before we talk about technology, I did want to put up this slide, which really emphasizes what the ethos of the foundation is. This notion of equity, that every person should have an opportunity to have a healthy and productive life, which underpins our work and, in fact, the work of many of our partners as well. But how do we do that? Well, we are focused on infectious diseases as a particular problem. That's not that we neglect all the other problems, and even if you approach an aspect of health like infectious disease, you need to think about the broader context. Issues like water, sanitation, financial services, agriculture, nutrition, all play a role. And I often get asked, well, what about the emerging epidemic of non-communicable diseases in developing countries? And we have an intersection with that as well, but for now, our main focus are these vulnerable populations that suffer from infectious diseases that have largely been eliminated in other parts of the world. One of the issues has been, how do you actually represent the problem? And how do you represent the problem in two contexts? One is actually the tremendous progress that has been made. This is the under 5 mortality decline, this to less than half what it was in 1990, which is amazing. But then also, how do you present it in a way that looks to the future? Because a lot of technology science, a lot of interventions along that line are things that are going to be available in 10 years hence. And it's not necessarily that helpful it's useful, but it doesn't inform you enough. What is the situation today? You need to be able to project into that future, because that's the world where your intervention, your product will actually live. And if you have the wrong context for that future projection, it's easy to have the wrong kind of technology applied. So we've come up and we worked for a couple of years on this way of projecting into the future, and it was used at the United Nations General Assembly at our Goalkeepers event. And I think it's quite an effective way of showing people where we stand today, where things are going to be 10 years plus hence. But more importantly than just the estimate, it shows you over here what the envelope is of options. The upside, which is the green, that's where we might be if things go really well, and the downside, which is where we could go if things actually don't go as well as projected. And what you can see over here is the difference between upside and downside is about 1.3 million deaths in this under 5 age group. So there is a big differential, and it can make a big difference. I want to make it clear that anything that the Gates Foundation accomplishes in these regions is really a tremendous partnership. And as much as we're engaged, we have multilateral partners, there are NGOs on the ground, there are governments that are invested in this type of development work. And these are some of the key multinational partners that we've worked with. There's always a context to health problems, and this is the principal background to the health problems that we face, because you don't have an epidemic out of control of HIV in the US. You don't have an out-of-control epidemic of tuberculosis, and you don't have malaria except for occasional cases that are imported. But you do have it in these regions where poverty is pervasive. And you'll see that as much as there seem to be continuing progress on the under 5 mortality, there's a leveling out of progress in the poverty. And the percentage, 6%, may seem, well, that's better than it is now, and maybe that seems to you like a small number. But with the burgeoning world population, that's hundreds of millions of people. And that remains a real focus. So let's think about the burden of disease and what we do about that. One of the questions, the most frequent questions actually that I get is around, well, there are these immense problems, and then there are lots of potential solutions. Some of them are products, some of them are new pathways of care. Community-based care for HIV is something which is very promising. There are diagnostics, there are vector control. Out of these thousands of different options, how do you invest in? Usually this comes to me as a question when somebody's effectively asking, why didn't you invest in my idea? And the response would be, well, there's some ways to think about this problem. So I'm just going to give you a quick snapshot of how we look at this issue of how to select what might be the most useful ideas out of the sea of ideas that are out there. And this is a bubble chart over here. Just a quick run through. So the size of the bubble equals the amount of death and disability you can prevent with the intervention that's being proposed. So you can see some of the benchmarks are bed nets for preventing malaria, and there's also voluntary male medical circumcision to reduce the transmission of HIV. Those are two things which exist now. Hence, on the probability axis at the bottom, they're at 100%. They already exist. Everything else is less certain because it's in the development phase. And that's a somewhat subjective assessment of how likely, for technical reasons, is this thing going to ever work. But you can see on those two interventions, they're huge, and those bubble sizes are in the 100 million of what we call DALYs, disability-adjusted life years. That's a huge amount of real suffering that is averted, practically speaking now, by these two interventions. The other thing we look at is this axis of cost effectiveness, because there's a limited envelope of funding, and how do we allocate that to the most important elements of what we're working on? And on that axis, you can see that the circumcision is in fact cost saving, and that's because people do not acquire HIV, they don't get opportunistic infections, they don't go into hospitals. It actually saves money for the system. On the bed nets, that's about $100 per disability and death life year. And that turns out to be very cost effective. So we have those two known benchmarks, and then anything new comes in is arrayed against them, and we have a look at where they fall out. Now, I don't want to oversell this because of the uncertainty of the data. There should be very wide confidence bounds on each of these bubbles. It should be surrounded by a big fluffy halo of we don't actually know exactly. So the way that I use this is mostly not to make big mistakes. Arrayed between the purple large bubbles over there, you can see a little blip that is hookworm. And that was a hookworm vaccine that we were invested in a couple of years ago. And some people thought that that was fantastic. The reason why it's so small is because each of these dots is actually a comparison to the existing treatment. And for hookworm, there is a drug that gets given called albendazole in these mass drug administration campaigns. Gets given to hundreds of millions of kids on an annual basis, and it's pretty effective in clearing up the hookworm. The only problem is, of course, it has to be given annually. You can't just do it once and you're done with it. But in any case, that's why the vaccine, nobody's made a vaccine against a worm before, so I think it's generous where it is on the probability axis. But it's a small dot because the drug treatment here is pretty effective. And a vaccine, if we were lucky, if there ever existed such a thing, 60% effective. So that small dot drew attention because, as you can see, on the cost effectiveness, estimate would be about $10,000 per disability life year averted. So very expensive compared to malaria bed nets. And the first thing we did was we looked at that program and ultimately decided to abandon that program, much to the chagrin of the group that had been working on it. But that's the kind of usage of such a type of portfolio analysis. Let's turn to the big three. Malaria, tuberculosis, HIV. And I wanted to just give you a quick snapshot in each one of some new approach or some perturbation of an old approach that is being deployed now that I think is quite interesting, that hasn't been fully appreciated, but could make a big difference in each one of these. Many examples that I could generate, but I'm picking just one in each of these cases. And let's start off with malaria. So if we look at the map of malaria back in 1990, we see really a global problem, just the north and the south that seems to be spared in this regard. And there's been a lot of progress because you move forward to 2017 and we see the residual malaria problem, which remains substantial, particularly in Africa. And the real problem is in this belt across Central Africa. And Africa is contributing more than 90% of the almost 500,000 people who die every year still from malaria, and most of those are kids under the age of 5. Once again, this is the same type of graphic of projecting forward, and this is not looking particularly good. We project forward to 2030, and the expectation, if we do what we're doing now, is that we actually stay where we are right now in terms of the new cases per 1,000 people. But what's interesting about this is that there's such a wide span of what could happen. On the upside, and this is an upside which doesn't include that somebody comes up with a fantastic new vaccine. This is actually much better deployment of all the existing tools that we have. The upside is that we get very close to elimination of malaria. And the downside is that we're back at this peak that occurred, about 10, 12 years ago, before the Global Fund and those instruments started to have impact. So this is a huge difference. Where's the world going to be in 2030? Did we get the upside? Are we there in this horrible nightmare that malaria is resurging? And all of these are quite possible outcomes. Well, we obviously, because of the immense problem over here and the possibility that a lot could be done to change the outcome by 2030 even, are very invested in new tools and new ways of approaching malaria. There are new kinds of insecticides. At least 2 new insecticides will be approved this year. There are new vector control technologies. There are new drugs. There's a lot of activity on the intervention side in malaria. The problem is that there already exist bed nets, there's indoor residual spraying, a lot of options that exist right now. And in a particular territory, the problem that you confront is out of the 10 possible options, which are the set of options you should deploy in a particular circumstance. And it's quite a logistical nightmare to think about how you would do that. The infrastructure to do it is very limited, so you've got to be judicious. You can't just say, let's do it all. that's obviously not going to work. So you have to sub-select what you actually do. And we had been very invested in doing a lot of operations research, as people call it, to test out different combinations. But now we've got into this combinatorial overload. If you have, let's say, 10 new things, the different mixtures would end up by us doing operations research well past 2030. We'll still be busy with that in 2050, just doing the operations research, if that was the only approach. So malaria is a fantastic example of where I think in silico and computational approaches are going to be the dominant planning and strategic way in which we make these choices. And malaria, because of the investments in modeling, Nathan's group, he'll speak a little bit about this, I guess, has been one of the key groups that has built up capacity in that regard, is one of the places where this is going to work out first. And let me give you a little example of what I'm talking about. So Zambia has done quite well in reducing the malaria burden in the central part around the capital, Lusaka. But there are some places where it's been quite intractable. One of the intractable parts of the burden in Zambia is down in the south around a lake called Lake Kariba. And it's a very wet environment on the banks of Lake Kariba, typically, and certainly it is seasonal. There's a wet season and a drier season. And it's been very difficult to actually get hold of this malaria problem around that lake region. So we have a simulation, which is probably one of the largest simulations of this epidemiological type that has been done, which incorporates very realistic aspects of the exact geography. It uses geospatial maps of that region. It uses the mosquito populations that are present there, the types of mosquito, the types of the, even down to the immunity that's present in the population. So it is a very, very detailed map at scale of an entire region of the country of Zambia. And if you look over here, on the top, you can see a map, the little red dots, as you can imagine. Where it's red is a hotspot for malaria, and gray is malaria is decreased. We took data over a couple of years, from when it was high to when it was reduced to when it was high again. On the top chart is the real data, and on the bottom set of maps is the simulated data. So what that is just showing you is that the simulation actually does a pretty good job of capturing what the real data shows you. And let's see if we can just run this simulation. So I'm going to step. So what you'll see is in the first, and this is just in terms of computer steps, but it corresponds to months in the year. The first 2,000 to 3,000 steps, you see it go down, and you see it resurge again, and you see it go down, and you see it resurge again. And then in the final part of this iteration, what you'll see is from about 20, there it's down, and it's coming back again. And then from 2014 through 2017, there was a very intensive effort to try a whole combination of interventions. Let's see what happens. Okay, so we had resurgence. So it looks like this set of interventions wasn't adequate, although it was actually, in some ways, quite an intense set of interventions, doing things like increasing the bed net coverage. Also, there's another technique, which is actually mass drug administration to the entire population, because a lot of the hidden reserve is in people who don't actually present and being sick with malaria. So you just actually treat everybody in the population. That was adopted here as well. So somehow this package of interventions didn't work out. Now, we could have done a study, which would have taken us about 4 to 5 years to find that out, but we have the simulation. So you'd have to believe that the simulation actually replaces some of the study. It's really the combination of doing now smaller, quicker studies and this kind of simulation, which will enable us to short-circuit some of that tedious process of selecting interventions. I'm going to skip through a similar simulation on Madagascar, as fascinating as it is, and we'll move on. Anybody interested? I can show you afterwards what the Madagascar simulation is, which is at the level of that entire country. Tuberculosis, one of the quintessential diseases of poverty. It exists only where there's poverty, and there's some other circumstances. It was resurgent in the US around the HIV epidemic over here, but has since abated, and you get a couple of cases. Usually they make the press over here, and they're usually related to, potentially drug-resistant TB. But 1.4 million people died last year from tuberculosis in the developing world. So there it is a problem that remains, and these are the dimensions. So what's interesting about this projection into the future is that that low point in 2030 is what the global World Health Organization goal is of where we should be by 2030. Now you can see where we are now in terms of cases per 100,000 people. And it's interesting, so the number is what, 140. In parts of South Africa through which I was traveling, it's more like 600 to 800 per 100,000, which harkens back to the tremendous tuberculosis epidemic that occurred at the turn of the previous century, or was at its zenith at the turn of the previous century in New York City, where it was about 600 per 100,000. But in any case, it's interesting that the global goal doesn't look particularly attainable, even in the upside. And, we'd have to think about what we do about that. But here's one thing about TB. We've got drugs which can cure it if taken over the 6 months for the average type of treatment. It's not fantastic, a 6-month treatment, but it is curative in virtually everybody. There is this problem of drug resistance that's emerging, but that is still a relatively limited problem. The problem with TB we see in most of the countries is that people are not tested because testing is difficult. It's either microscopy, you've got to have specialists with microscopy. There is a new nucleic acid test called Gene Expert, which works so-so. It doesn't actually get down to the front lines of where somebody comes in a clinic. So we've put a lot of effort in how do you better diagnose TB. Everybody's got a cough. Everybody has an occasional fever and weight loss. These kinds of non-specific symptoms, very difficult for a clinician or a healthcare worker to diagnose TB in many of these places where you have other competing infections like malaria. One of the interesting outcomes in our work to produce a diagnostic, and I just met up with this group a couple of weeks ago, and I thought it would be interesting to show you what they've been doing. It's a group called Eterna based here in San Francisco. And one of the amazing things that we found is that there is a gene signature which you can find in the blood of people who are at risk for having TB that predicts up to 12 months ahead before they actually become clinically symptomatic that they are at a very high risk in the next year for actually developing active TB. And initially, I was one of the first skeptics that such a test would have that kind of power, but it has been repeated a couple of times now. And it is unfortunately a number of genes that you need to look at. It's not just one. So that makes it a pretty complicated test. The group here in San Francisco had actually managed to reduce the number of genes that you need to look at to 3. But you needed for those genes to be present in a certain ratio. And then if that ratio was met, if the level of the 3 genes in terms of a little formula was above a certain threshold level, that predicted the risk. So how do we make a diagnostic out of that? Well, we have to have 3 diagnostics essentially, and then we put them together, and then there would be this little computer algorithm which would see whether they were at the right levels. That's a complicated thing. That's not going to happen in some frontline clinic. So this group got together and they said, well, what if you can make a switch that would just switch on if those 3 genes were active in the blood? So you put the switch somehow into the blood sample and it would just switch on and light up if that person was going to be susceptible. And that seems like a fantastic thing. How are they going to do that? Well, they've been working with RNA molecules, the nucleic acid that many of you will be familiar with, because RNA is a very flexible molecule. It has this kind of switching behavior. And if you make the right RNA construct, in the right circumstances, it can change its conformation pretty radically. And the amazing thing is that as much as there's been a lot of advances in terms of protein folding and computational approaches to predicting how proteins fold, RNA is a more flexible molecule, and computational approaches thus far to predict RNA folding completely fail. So Eterna has got this gamification approach whereby they put out challenges to gamers, computer gamers, and they ask them to try and solve the problem. But they make it into a format that the gamers don't have to be molecular biologists to actually engage in it. They just need to look at a shape, and then they get a challenge of how can you make something that looks like this transform into the switched on state. And in this experiment, they had 10 completely correct solutions, because the other thing that Eterna does is they actually go out and make the molecules that the online gamers come up with to test whether their results are right. And then they put out the results. So they had 10 perfect solutions. And, you know, will that be the basis of a really effective frontline test? This is the idea of what's going on, I guess. It's a simulation. HIV. Let's see what the curves look over here. Now, this is an interesting set of projections into the future over here. What it shows is the peak of the epidemic and the tremendous progress that has been made. These are the number of deaths. These numbers are very small because they are the global aggregation, so we're dividing by 7 billion people. But in the areas like Southern Africa and East Africa, there's a raging epidemic. These numbers would be much higher, of course. But what you can see is that we would have continued progress. That's the projection, the estimate. I wouldn't say that that's fantastic. On the upside, of course, we would get pretty much down to where the epidemic was right near the start, and that would be a pretty good outcome. I'm more concerned about the negative. The negative over here is largely due to how much we're prepared to fund this ongoing work, given that it seems that HIV has almost disappeared in the north as a real problem in people's minds, because it seems to be a solved problem, whilst it is absolutely not a solved problem in these regions. And there's even another little addition which gets us even worse than the worst case, and that would be if the US government were to impose the additional cuts on PEPFAR that have been actually mentioned as potential policy going forward. So that's a complete disaster, because then we're halfway back to the peak of the epidemic again in terms of the number of deaths. What are we going to do about this? There is an element of targeting over here, and one of the populations that are most vulnerable are young girls, young women, and they have a particular susceptibility which we don't quite understand, which may even be different in different geographies. Particularly a problem down in the KZN province of South Africa. And how are we going to protect these young girls? There are a couple of different options. The one that I'm most excited about is the one in the middle over here, which hasn't really been talked about very much. Now, I'm putting aside the fact there's a huge enterprise around a vaccine for HIV. That is some ways off. We have 2 big vaccine studies starting in Africa. Well, one has started September last year, and the other one starts in December of this year. And we'll take some years to see where those vaccines get. Quite unlikely that they are going to be the magic bullet and the 80% effective vaccine that everybody would like. But hopefully they will pave the way for that, or themselves actually have some moderate degree of efficacy. More immediately, before we get to a vaccine, we're going to have these interventions, the one in the middle, which is an implant, much like the contraceptive implants, that would be put under the skin, and it contains a long-acting antiretroviral, which would be released over the period of about a year. So it would be prevention along the lines of a vaccine over a year, and would get around the issues with PrEP, if you have followed that story, where the main issue in Africa has been around compliance. And for that reason, it has turned out not to be an effective intervention. So there is a particular product which is backing off research that has been done around a similar kind of product that's been developed for type 2 diabetes, where people have got an implant, and we're using that same technology applied now to HIV. And I'm really excited and think that this could be a real game changer in the HIV story. So that's where we've landed with, but in any case, so hope for optimism on all three fronts, but a considerable degree of caution around some of those downsides that I mentioned. In summary, I wanted to come to 2 points that I feel are important to make around this use of technology for development. The one is that given the array of technologies that I've put forward to you, it challenges this notion that somehow you need just very simple things for development. What I've seen, and I was coming from a different place previously, which is that to overcome the broken delivery systems, you often need a more advanced technology and a very sophisticated technology to overcome those barriers of not having delivery. You need the vaccine which works with a single dose, the vaccine that can sit on a shelf for 2 years in 40 degrees plus, 40 degrees centigrade plus. And those things are not necessary when you're delivering out of Walgreens down the road over here. The other thing that I would highlight is this notion of actually understanding the patient journey, what those communities are about, how they interact, how the healthcare workers interact with them. If we've made mistakes, they've all been in this area, which is that we've conceived, in places like Seattle, a technology, and then it's gone out, and it may be slightly wrong in terms of its profile. But in this development area, being slightly wrong is being completely wrong. That's having zero impact versus something which you hoped would be very impactful. So there's a continuous need to understand very exactly what is happening out there, profiles that are useful, before you go ahead willy-nilly into technology development. And with those 2 final thoughts, thank you very much for your attention. Thank you.
Trevor, we're running a little bit behind schedule, so I'm going to forego the introductions for the other speakers. You can find their bios in the program. Our next speaker is Dr. Nathan Miravold, who's the founder and CEO of Intellectual Ventures and its Global Good Division.
Okay, so if you're like me, technology has transformed your life. It's transformed your life in all kinds of ways, how you work, maybe also how you play, how you keep in touch, what you consider to be essential. And it's great that technology has changed our lives, but we didn't actually need our lives changed. It turns out that the reason we were able to change our lives so much is that inventing is basically a form of magic. In Harry Potter, people get to utter spells and wave a wand and amazing stuff happens. With invention, it's some nerdy person thinks of something, and it can be just as momentous as in Harry Potter. It doesn't usually happen instantly, and you don't say sort of quasi-Latin phrases. But the magic that we have used in the 21st century so far has given us pretty much tools and toys for rich people. Now, I've been in the technology industry my whole career, so I'm not saying this is a bad thing. And depending on the technology, it might be a tool like CAD programs or things for engineering. It might be a toy, or like drones, it might be some of both. There's some pretty tool uses of drones, and there's some pretty fun uses of drones. I think it's really important for us to use this magical power of invention and innovation to change the lives of people who really needed their lives changed. People at the bottom billion in the world from from any perspective. You can look at the bottom billion from healthcare or from poverty. It's pretty much the same folks. And those are people who need their lives transformed. But the iPhone 10 isn't how to do that. You need to have other kinds of technology that will focus and try to make a magical solution to what's otherwise an intractable social problem. Now, when I say this to people in the world of global development, they often say, oh yeah, we tried a high-tech thing and it failed. And I always laugh when I hear this because high-tech things always fail. This is actually a picture of a testing session for new football helmets. Today we would actually use sensors in a robot because this guy's head probably wasn't so good afterwards. For example, there were 33 search engines launched before one of them was successful. And the world didn't say, oh, search engines, yeah, we tried that, it failed. No, technology world is all about failure. 32, at least, search engines failed before we got Google. Yeah, a lot of times when we look at the developing world and people say, oh, we tried this, it didn't work, tried that, it didn't work. Well, okay, you got 30-some more to go. And part of the point here is that inventing anything is hard. Even if you're creating a search engine in the middle of Silicon Valley, it's hard. That's why those other 32 companies failed. And of course, if you're trying to solve a completely intractable problem of poverty or health care in an area where there is none, you should expect that's not going to be any easier. It probably is harder, but that doesn't mean you shouldn't try. And I think you have to try to you have to try to use the most powerful tools you can. But that doesn't mean you have to recapitulate the history elsewhere. This is actually a picture from the movie Caddyshack of an early idea of what a mobile phone was like. It actually does have all those features today, just doesn't look like that, fortunately. It turns out that the developing world is not locked into doing the same thing that we did in the developed world. And a great example of that is if you look at digital money, the country with the largest digital money economy is Kenya. It's not here. Here, you know, it's a miracle to have a credit card with a chip in it. That's like a new thing. Half the places you go in the US, oh, we don't have our chip reader yet. Whereas in Kenya, a huge amount of the economy is transacted entirely with cell phones in a system called M-Pesa. They didn't have to try to go through all of the broken ideas that we did. They're able to jump directly to it. Another issue that's built actually on a previous success, which is cell phones. People in the developing world are never going to have landlines. I mean, we in this country, young people often don't have any landlines because you don't need them. You have cell phones. Well, the developing world is going directly there rather than going through a period of 1950s style phone lines everywhere. So because we feel this way, our company created a unit called Global Good, where we try to invent for the poorest people on Earth. And fortunately, we have some powerful and wealthy friends. This is Bill and I here are playing with caterpillars, which are actually part of one of our projects. We actually are trying to determine the quality of milk using caterpillar blood. And that sounds pretty silly, but really we're doing it. And so we work on all kinds of things that try to apply high technology ideas to innovate for the developing world. The computer simulations that Trevor showed were made by one unit of Global Good. And so we model epidemics malaria, TB, polio, and others. We also work on devices. This is a vaccine container which keeps vaccines cold without any power. It's basically a really good thermos. Trevor had a picture of one on the side of a camel. They've gone all over the place. These containers turned out to be essential for the 2014 Ebola epidemic. We were able to make a modified version that could keep the Ebola vaccines at the correct temperature. And the reason that this took us 5 years and at least 10 different generations of things before we got something that really worked. We also have a couple of other cold chain solutions. We have a kind of a fridge called the Meta-Fridge. That is not a portable solution. That's made for places where you've got some power, but it's really bad power. Of course, the reason we have to invent here at all is that Africa does not have a good power grid, or it doesn't have it uniformly across where people live. You could say, well, gee, let's wait for that to happen. But millions of people will get afflicted by diseases that are preventable if we just wait. So instead, we said, well, let's make a fridge that can go for a week without any power. Or on the back of the person on the motorcycle there is our latest project. It's another kind of a cooler. This is a very portable backpack cooler. It has the neat property that you can sort of turn it off and turn it back on again. But it's not electric. Another big issue is diagnostics. It's very hard to treat diseases if you don't know what they are. And surprisingly, it's really hard to determine many of these diseases. For example, it's actually hard to tell pneumonia from malaria. And that might sound crazy, but in fact, if a little kid has an extreme fever, chances are it's one of those two, but you don't know unless you've actually done a test. Well, the trouble is the tests that are developed for the developed world, for the rich world, either rely on there being very sophisticated pathologists and testing labs, but Africa doesn't have those, or they are really expensive because we have plenty of money in our healthcare system. So, actually, go back. So we've developed a malaria test similar to a pregnancy test in that you put a drop of fluid on, this time the fluid's blood, but it's about a factor of 100 more sensitive than previous versions. There's a bunch of other diseases that you diagnose with a trained microscopist. The problem with those is you don't have a trained microscopist, or you don't have enough of them. And particularly if you're trying to treat drug-resistant forms of these diseases, it's all the more important to try to diagnose them. Without the trained pathologist, what do? This, by the way, is what the trained person is doing. They're looking at a microscope slide that has been stained, and you see those little purple dots? Those little purple dots might be malaria. But there's several other things they might be, which is why you need lots of training. And this particular slide, the person's got plenty of them. They have a fairly high case of parasitemia. They've got a lot of malaria in their blood. For someone with a mild case, you have to scan the microscope over and over and over. Every one of the fields looks fine until, oops, you find one. And here here's a clinical setup where they have little counters. You need all this to work in places like this or places like this, where having tons of these slides and having an analysis thing isn't really feasible. So we collected malaria slides from all over planet Earth, and then we've developed an automatic microscope, and we've developed machine learning software, which can spot those little purple dots. And we've got it to the stage that our machine learning software is now better than humans. Now, it's especially better than humans if the humans aren't perfect. It's actually better than the best humans. And it's really better when you're tired or you're bored or your microscope isn't very good or you don't have very much of a case of malaria, so you have to sort through an awful lot. So that all goes into this little microscope. We've partnered with a company that in China that builds microscopes. And this is going to be fully automated. You take a drop of blood, you put it on a simple thing that puts the stain on, you slide it in, and it goes bzz, 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 bzz. It comes back and tells you whether you have malaria. Now, that was a cool thing to do for malaria. Here's sort of another view of it. Turns out there was another side effect. For whenever you do machine learning, you have to build what you call your training set. And the training set is all of the examples that you use to train the software. Well, we thought, there's got to be another use for this. So we, in fact, made a little software package, partnered with another company, that reuses all those slides to train humans. So whereas normally you train the software using what experts have, we're actually trying to do the reverse now. We're taking the training set for software, and we're repurposing it to also train humans. Now, malaria was one of the things that we can address with this platform, but it turns out there's lots of diseases that have the same pattern. You take a sample, you perhaps stain it or do something else to it, and then a trained person looks under a microscope. So whereas we have one application right now for malaria, Leishmaniasis, which is another terrible disease in tropical areas. It's transmitted by a sand flea rather than a mosquito, but it also is something you diagnose with the blood. Chagas disease, that's a disease that is spread by a beetle that sucks your blood. That's mostly in South America, but it's actually gone all around the world. And even cancer, all have this same thing. So having created a platform that's about automating microscopy and using machine learning, we're going to try to do it for all these things. So, as I said when I started, inventing is like magic. Having a great idea has no limits. There's unfortunate physical limits to what you can do in the real world, but in the space of intellectual ideas, new ideas can be arbitrarily powerful. And I think it's important that we use that magic to help the poorest people on Earth. It's great making tools and toys for tech people, and the tech industry will keep doing that. But if we can get some of the world's smartest people to think at least some of the time about problems like this, I think it'll be really important. Thanks.
Terrific. Okay, our final speaker, Rosario Mungo, is a veteran broadcast science journalist with Kenyan Broadcast Corporation.
Thank you. So how many have taken coffee today? How many cups? Even 3, even 5. But do you also know that coffee was once a beverage under siege? Do you know that it was once a subject of, of disruption and a subject of fights? So it was an innovation that it was banned on several occasions in the Eastern and European and in the Middle Eastern areas. So that's just one of the innovations that are chronicled in Calestus Juma's book on innovations and its enemies. Yeah, so he talks about several innovations that were under threat at that time and what used to make governments fight and people fight because this innovation, such as coffee, the coffee that we take every day, was supposed to be taking the place for wine and beer and also competing with tea. which many people did not like because they were going to be upstaged from the market. So lots of innovations that are covered in Africa are mainly in the areas of agriculture, health, and environment. And some of the platforms of innovations include ICTs, which are mainly more liked by people in developing countries, and that's because they are safer. And these are mainly found in the mobile phones and in internet technology, as we'll come to see. Some, like nanotechnologies, are least explored, and we have also innovations in the areas of geographical information systems, and also biotechnology, which presents a very big controversy in countries such as Africa, and especially a country such as Kenya. But what stands out is that innovations must be relevant to the local environment. Otherwise, it will be resisted to the very end, and it also must be driving at a problem. So that is from Innovation and Its Enemies. And it says that exponential growth in technical knowledge is making it possible to find low-cost, high-technology engineering solutions to persistent problems. You know, the sort of problems that face people in developing countries can be solved through high-technology solutions. So for developing countries, most of them, like I said, revolve around information, communications, and technology, because these are considered safe. So long as I don't have to use that innovation, you know, so long as I don't have to consume it, so long as I don't have to eat it like the biotechnology innovations, so long as I don't have to eat it and I'm not sure that it will affect my health, then I'm so willing to use it. And that's why the innovations, most of them revolve around ICTs, because it's about exchanging of information on a mobile phone. So a number of these are available in Kenya and what have been covered in the media. We have one called M-Farm, which is just a way of connecting small-scale farmers with each other so that they are able to know where they can buy farm inputs and to know how to access markets. So it was invented by a group of young ladies who saw the need in small-scale farmers. There's one called iCow, which involves the use of mobile phone to encourage best practices in farmers. Again, it's just about exchanging information, nothing to eat. So it remains very safe. So the agricultural ones, the ones that are found in biotechnology, so those are the ones that bring about lots of controversy and have been the subject of a lot of controversy and have been greatly resisted in a country such as Kenya. So among the biotechnology innovations include synthetic biology, transgenic crops, you know, gene editing tools, and these have been subjects of controversy because people, either because of misinformation, so that people are not sure that we are ready to, you know, to adopt such trends yet, so they've been resisted. So like in Kenya, there was a bill in Parliament on biotechnology, on the acceptance of GMOs, but that was time-barred because of back and forth, you know, back and forth from members of Parliament depending on interests. So some people rely on one side of the divide who are against GMOs. Some MPs rely on one side of the divide. So there's a lot of back and forth that they could not agree. So the bill was time-barred. Okay, some of the ways that, that innovations are covered in media include assessing the impact. For instance, This one was about fighting malaria in Zambia and the use of mobile phones to do that, the way in which communities are able to access information on ways in which to prevent malaria. And our second speaker alluded to this one, M-Pesa, which was launched in Kenya about 10 years ago, and it has been a success because even grandmothers in the village use M-Pesa. So it's a mobile money transfer system in which you don't even need a smartphone, you just need a general type of phone in which you can present money to an agent, an M-Pesa agent, and then they transfer, using your mobile phone account, they transfer the money to someone else. Across the country, now it's even being used in several countries, Tanzania, Afghanistan, India. And because the adoption rate was so high, it became a hit, and now people have to find ways of working with M-Pesa. For instance, Western Union now, there's a way in which you can send Western Union and still send the money through M-Pesa. So it has encouraged lots of partnerships because its rate of adoption was so high. But it also came in to address the unbanked populations. But this same innovation failed in a country such as South Africa because already there was high financial inclusion in the economy. So most of the users are for from low to middle income economy or earners in Kenya. And of course, they can use it as extended loans and savings and also for paying bills. So the trends in coverage, what I've realized that the media focuses on for the innovations in biotechnology, the trend is usually focusing on the risk and focusing on the controversy, where people are differing. That's where the media focuses on. So, and it's mostly not about telling us what is so unsafe about biotechnology and GMOs. It's usually about the controversy or the conflict that biotechnology invokes. Because of that divide, it's either you are against it or you are for it, and you don't really know the reasons, maybe because your allies are either for it or against it. So there's usually lack of information there. And another trend in coverage is sensationalism and also conflict. One example is Uber. Uber came to Kenya not too long ago, and it disrupted the market. So Kenya was a country where taxis are so expensive. For instance, if you go to the airport, if you land in the airport and want to be driven using the airport cabs, you pay so much money, but Uber came in, and now even the taxi drivers at the airport now are willing to negotiate. When they know when you're waiting for an Uber because they're seeing you on your phone. Then they come to you to negotiate a price, They ask how much. I was in the airport the last time. So this guy comes and asks me, how much is he going to charge you? So I tell him, this amount of money. I can give you slightly around that, Whereas in the past, they were quite a monopoly. So they would charge whatever amount of money, and being an airport taxi, then they feel like they have a right, to charge you whatever amount. So the other trend in coverage involves scandals. Whenever there is a scandal concerning money or a fraud, then there lies media coverage. And the ones for the farms, for agricultural innovations, for instance, the M-Farm and the iCow and the mobile phone to fight malaria, Those ones usually focus on success stories and the impact to the poor people in community. So for most of this about exchanging information with farmers, there is not too much controversy about them. It's usually about how many farmers have benefited, and now that one depends really on the genre of coverage of the reporter. How many farmers have benefited? What did they used to earn before? What are they earning now? Can they now access markets for their products? So those ones invoke a lot of success stories. And we also have coverage in form of M-Pesa, in form of PR, where these organizations such as M-Pesa now, because they've grown so much, they're now expanding. They even have a foundation, So now they are able to do corporate social responsibility. So some of the issues they like to be covered include the PR activities. They like to fund schools. They build schools. So some of the coverage in that involves corporate social responsibility. So these are some of the headlines you would find. So I picked those to do with Uber. So that happened when the conflict blew up, and taxi drivers started attacking Uber drivers, in broad daylight. So those were some of the headlines you would find. So what are we as journalists supposed to be looking for as we cover innovations? We need to look at the affordability of an innovation. We need to really interrogate, is it affordable? Are the communities using it, and is it really working? Or are or are the masters just trying to really play up something that is not practical? Does the innovation actually work, and is it practical? Is the M-cow, or is it a practical thing? Can the farmer that cannot read, the farmer that is illiterate, but he can use his cell phone, is he able to use it? How about the impact? Does it benefit the people? We are supposed to show how, We're supposed to show how that sort of innovation has benefited the people in a certain region. And we really need to be aware of, promotions in the name of selling innovations. That's by interrogating. And then the facts and figures. How many have benefited? What were they earning before, and what are they earning now? So Africa has the opportunity of using whatever existing pieces of technology in order to leapfrog. And so media should source this and be on the forefront in telling people about the innovations that are coming up. And we also need, as journalists, to interrogate, and investigate government policy on technology. And we also need to report on research by scientists, every step of the way of the innovation, so that we are not going to cover them at the very end. At the very end, when they are done with something, and we wouldn't even know how to start reporting. So that's what sometimes that's what leads to shallow reporting. We are called to report in national interest and reporting objectively on how innovations are impacting businesses. And this calls for independent coverage. So in a country such as Kenya, or most countries in sub-Saharan Africa, a lot of areas, because of poor infrastructure, we're not really able to reach a lot of areas. For instance, the northern part of Kenya, journalists are not always able to reach because of infrastructure, sometimes because of insecurity. And we rely a lot on NGOs to take us to some of the places we need to do coverage. And even as they take us to cover what they're doing, you know, the sort of initiatives that they have begun in those areas, it's still important to maintain independent coverage. It's still important to interrogate what really they're telling us about their innovations. And in order to assess impact, it's important to interview the beneficiaries, the people in the community. How have they benefited from the technology that helps them to access markets for their produce? For instance, are they selling more about the technology to, you know, eradicate malaria? Have the numbers of deaths gone down? You know? And the impromptu interviews for spontaneity, when these organizations take us to report on their issues or on their discoveries in the field, they usually drag somebody along from the organization. And on the ground, they've already prepared, you know? It's not in situ. It's so arranged. So spontaneous interviews will also help to encourage independent reporting. In conclusion, journalists need to be more empowered, especially science journalists need to be better empowered to be able to report better and to be able to report, to be able to bring out the science in some of their innovations. Thank you.
Thanks, Rosalia. Okay, we're pretty close to the end of the session, but we have time for a couple of questions. If there are any, please come to the microphones that are in the aisles.
Hi, I'm Robin Lloyd. I'm with Undark magazine, published out of MIT. The innovations are really interesting, but one question or criticism I hear sometimes is that they exist in a socio-political context, and unless we address that, we're always going to be limited. Is there an answer to that issue?
Well, I mean, my answer is bullshit. I mean, if you want, of course, the problems of the developing part of the world are many and varied, and there are many social problems, and there are many political and governance problems. I don't have any way to solve those. And I think sitting back and saying, well, we have to wait to do anything until they have really nice governments and until they have really good health care, that's just bullshit. It's going to take a long time. It took us a long time in the United States. It took Europe a long time, hundreds of years, to go from crazy monarchies and so forth up to the governments that we have today, as imperfect as they are. There's okay. Saying, oh, we shouldn't do innovation because really these are social problems, I have no use for that, personally.
I'll give a polite version of Nathan's bullshit. So, as I mentioned, I'm just back from Ethiopia and South Africa, two countries with very substantial socio-political problems. And I'm always impressed, and as I was impressed on this trip, is that in both places, despite the reporting, which mostly focuses on those problems, and probably appropriately so, underneath that, there are layers of people, whether they be in the government or they be NGOs on the ground, who are doing a tremendous amount of work, who are very committed and are able to work through. People have, you know, even in places like Democratic Republic of Congo, where it's chaotic in some ways at a certain level, when you go beneath that top layer, you get down into what's actually happening. There's a lot of productive work that gets done through all the changes and through all the chaos. And those are the individual people, the champions, the partners that we look for, people who can work and sustain themselves through all of that chaos that goes on.
So I feel like they exist in a political context, but after the innovation is up, so that most of these people behind the innovations really want to be, you know, in the good books of the government of the day. So they want to please the government so that their innovation just, you know, goes smoothly in the market. That's after. Before, I don't think so.
I wanted to ask about innovation versus development. On one hand, you probably want to share these technologies freely with developing countries so that they can solve their problems. On the other hand, people have to derive profit. You have intellectual property that you need to protect. And then there are also, I think that the Gates Foundation and Global Good have to have sort of different spheres of influence so that you can build on each other instead of getting in each other's way. Could you talk about those issues, and particularly the idea of how the intellectual property is managed?
Well, I tell you what we do, which is, in general, we want to have these innovations we make for the developing world go there and be effective. Now, if you insist on saying no one can make a penny from it, who's going to go do it? So we tend to partner with companies in China, for example, where we're not going to charge them for the intellectual property for things shipped to the developing world. When they ship it to middle-income countries or high-income countries, that's different. Then we ask to get paid. But even on the things that we give them no royalty on, we expect they're going to make some money, because that is what encourages them to go do that. So, and we found in general the companies that are most, there are some American companies that are interested in doing that, but the places like India or China are full of companies that very much want to address Africa and the developing world. They want to have business there, and so they're a lot more prone to do all of the work to develop a product.
So in certain parts of the geographies we work in, there are minuscule markets, private markets, and I think that the primary support for these products comes from the international multilateral instruments like Gavi and Global Fund, and that's clear. But there are some opportunities beyond that which I think are interesting. One of them is what we call dual purpose products, or at least dual market products. And take an area like TB, where there are a profusion of new drugs that are coming along. Now those TB drugs are, one market would be a place like the US, where they might fetch a very high price in terms of multiple drug-resistant TB, but there's so few cases that doesn't really support much. But there are a whole tier of middle-income countries, which would include China, South Korea, Brazil, India, that have got substantial TB burdens, where these could be potentially useful products. So a company could target these middle-tier countries with these dual-purpose products, and they could use the returns made in those markets to effectively subsidize their work and their production for other parts of sub-Saharan Africa, for instance. So we've been looking for that category of product, and there are a number of examples that we could go into beyond the TB one.
Great. Let's thank the speakers again.